characteristic biopsy feature of most characteristic bio feature of it is neurofibrillary tangles important. ठीक है? And neurofibrillary tangles are due to deposition of marker of Alzheimer's is Alzheimer's का marker is gene mutation का second drug of choice for Alzheimer's is gross appearance of brain will show fascinating gait is a feature of stoop posture is a feature of postural instability is a feature of freezing is a feature of triad of Parkinson is the most common is resting, most common is most specific is and upper limb rigidity is called as lower limb rigidity is called as most common site affected in Parkinsonism is deficiency of which neurotransmitter in Alzheimer's. Most common site affected in Alzheimer's nucleus of midnight basal. Done, कोई issue नहीं है. Now talking about the drugs for Parkinsonism, guys. What is the drug of choice for Parkinsonism? Anybody? Usually in younger patient we give pramipexole or ropinirole. दोनों बेसिल Alzheimer's में दी जाती है. Drug of choice for Parkinsonism. Pramipexole and ropinirole. Which group they belong to? They are D2 agonists. These are pramipexole is a ropinirole is a D2 agonist. So they will increase the levels of dopamine in the patient. Okay. Then the other drugs which can be given. Which antiviral drug is given in cases of Parkinson? This was a straight question. Antiviral drug given in cases of Parkinsonism is amantadine, which is also used for influenza. Right. Next, what are the other drugs which can be used? Anybody? The most effective drug, if I ask you, the most effective drug, or usually in elderly patients of Parkinsonism, then the drug would be levodopa and why carbidopa is given? It will inhibit peripheral dopamine decarboxylase enzyme, so it will avoid peripheral side effects of levodopa. Okay? So please remember, most effective drug in Parkinsonism, levodopa carbidopa combination. Along with that, definitely we can even give COMT inhibitor, that is catechol O methyl transferase inhibitor, and this drug is known as COMT inhibitor is entacapone is. Then we can even give MAO B inhibitors, that is monoamine oxidase type B inhibitors. These will also increase dopamine levels. These are drugs like rasagiline, selegiline. These are drugs like rasagiline is a ठीक है. Parkinsonism के drugs हो गए. If a patient of Parkinsonism comes to you and there is very severe Parkinsonism in this patient, one of the treatment options that can be employed is anybody? Deep brain stimulation. So why I have given it to you? Please remember, there was one question, a classical case of Parkinsonism. Okay, they had given and they had asked all of the following treatments can be given to the patient except. Okay. Options were pramipexole, levodopa, deep brain stimulation, and rivastigmine. It is rivastigmine which cannot be given to the Parkinsonism patient because rivastigmine is a drug used in Alzheimer's. Okay, this was a recall question you need to know. Then ये ठीक है, ये हो गया. Drug induced Parkinsonism में drug of choice है. Drug of choice of drug induced Parkinsonism that we will discuss further. Next, Parkinsonism and Alzheimer's both are neurodegenerative diseases. One causes cortical dementia, other causes subcortical dementia. No issues with this. Moving further, if the brain biopsy shows these type of cells, okay, the neurons having a nucleus which is pushed towards the periphery, and there are grape-like vacuoles or empty spaces within the neuron. What kind of appearance would be seen in the brain? It would be a sponge-like appearance. This is called a spongiform encephalopathy. This is called a spongiform, and spongiform encephalopathy is a feature of Prions disease. And the most common human Prions disease is Creutzfeldt-Jakob disease. Most common human Prions disease is on biopsy in Prions disease we can find spongiform encephalopathy. One of the important risk factors was brain eating cannibalism. Okay. Prions disease is due to accumulation of which type of protein? So there is an infectious amyloid protein which accumulates. That protein is called as PRPSC, that is Screpy protein. So Prions disease is due to accumulation of which protein? Screpy bolo. Prions disease is due to accumulation of Screpy protein, PRPSC. Okay, this is an infectious abnormal amyloid protein which deposits in the brain, and that causes spongiform encephalopathy. Most common type is Creutzfeldt-Jakob disease. Others can be fetal familial insomnia, Kuru. Okay. Next, done with this. This is also neurodegenerative disorder Prions. It is 100% fatal because we do not have any drug for it. Next, this well-known personality, a very famous scientist, he was Sir Stephen Hawking. And Stephen Hawking was diagnosed with a neurodegenerative condition known as amyotrophic lateral sclerosis, also termed as ALS. Amyotrophic lateral sclerosis can be sporadic, but some of the cases can even be genetic. Which gene mutation is associated? Superoxide dismutase, one gene mutation. Superoxide dismutase. So which gene mutation in ALS? This was the question. Which gene mutation in ALS? Superoxide dismutase, one gene mutation in ALS. Now this superoxide dismutase usually neutralizes the free radicals. But if this enzyme is mutated, superoxide dismutase, free radicals would not be neutralized. There will be increase in free radicals which will attack the brain cells. Okay? And this is how there is a neurodegeneration occurs. Okay? So gene mutation is SOD1. What is the drug of choice? Anybody? Drug of choice is? So usually it is not termed as drug of choice because still we do not have 100% treatment with ribosol as well. Important, please remember, here you will find upper motor neuron symptoms or lower motor neuron symptoms. So here you will find upper motor neuron as well as lower motor neuron symptoms. Important. Upper motor neuron as well as lower motor neuron symptoms. जल्दी से differentiate करते हैं. Babinski sign is positive and Babinski sign is positive and Babinski sign is positive and spastic paralysis, rigid paralysis is seen in नींद आ रही है. Spastic paralysis is seen in spastic paralysis है upper, spastic paralysis है flaccid paralysis है the tone of the muscle is decreased in flaccid paralysis, which is seen in cases of lower motor neuron region. Tone of the muscle is increased in cases of spastic paralysis, which is a feature of upper motor neuron. But in ALS, usually upper motor neuron as well as lower motor neuron region, both would be seen. Important. Areflexia is a feature of lower motor neuron. Areflexia is a feature of spastic paralysis, flaccid paralysis, Babinski sign, areflexia, exaggerated deep tendon reflexes, exaggerated or brisk reflexes. ठीक है, ये 3 पॉइंट तो याद रखना ही रखना. इसी से you are able to differentiate whether it is the upper motor neuron region, that means damage to the brain or spinal cord, or it is a lower motor neuron region, means damage to the peripheral nerves. ठीक है. Important. Can anybody tell me Bladder and bowel involvement is seen in cases of ALS? No. So bladder and bowel involvement is not seen in cases of amyotrophic lateral sclerosis. Okay. With this, you can understand ALS important. Okay. इतना ही याद रखना है, ज़्यादा कुछ नहीं. क्या हुआ? Ear is also not involved, definitely. Yeah. Next question says a patient who is 30 years old presents with gradually progressive tremors and coriform movements. He states his father developed similar disease with mild symptoms in his 60s. Diagnosis. So first thing I would like you to tell me about this phenomena. Here they are saying the patient comes to you at 30 years of age and is having tremors and coriform movements. Okay? Whereas his father also developed some disease, similar kind of a disease. That means it is a genetic condition, right? But the father had a disease with milder symptoms and usually later in onset, right? So please remember, if the disease appears in a young age group in the next generation or with severe symptoms in the next generation, this phenomena is called as anticipation. If the disease increases in severity in young generation, or it is usually earlier in onset in young generation, this is called as. So grandfather को 80 में हुआ, father को 60 में हुआ, बेटे को 30 में हुआ. Grandfather had very mild symptoms, father had mild to moderate symptoms, son has very severe symptoms. This is called as anticipation. And anticipation is a feature of diagnosis. Tremors and coriform movements. What are choria? So choria are semi-percussive distal fast movements. Okay, these are called as choria. Semi-percussive distal involuntary fast movements are called as choria. And the diagnosis in this condition is Huntington's disease or Huntington's choria. Okay, choria is due to damage to which part of the basal ganglia? C for choria, C for choria is due to damage to caudate nucleus. Important. Then if I say distal semi-percussive slow rising movements, these are called as aciotosis. These are called as and that are due to damage to globus pallidus. Aciotosis is due to damage to and hemibalismus is due to damage to subthalamic nucleus. Hemibalismus is due to damage to. तो ये तीन चीजें इंपॉर्टेंट है, याद रखनी है कौन सा किस डैमेज की वजह से होता है. So here we have Huntington's chorea. As we know, it is a genetic disease. Please remember, it usually follows non-Mendelian as well as Mendelian pattern of inheritance. Most commonly, it follows non-Mendelian pattern of inheritance, and it is trinucleotide repeat expansion. It has trinucleotide repeat expansion. Which trinucleotide repeated? CAG repeats. Yes, we can find CAG repeats. More than 100 CAG repeats would be seen. Okay. So which pattern of inheritance is seen? Trinucleotide repeat expansion. Which pattern of inheritance? And which codon is repeated? Then it also follows Mendelian pattern of inheritance. And the pattern of inheritance would be autosomal. It is due to which gene mutation? Huntington gene mutation. Which gene mutation? Huntington gene is located on chromosome number. Huntington gene mutation follows which pattern of inheritance? Autosomal. And CAG repeats are due to which pattern of inheritance? Trinucleotide repeat expansion. Drug of choice बता दो चलो जल्दी से. Drug of choice for Huntington's chorea. Shabash. It is tetrabenazine. Drug of choice for Huntington's chorea. No issues with Huntington. Done. Moving further. This question says a patient presents with ascending bilateral flaccid paraplegia. Sometimes they can even talk about paralysis and even talk about symmetrical paralysis, right? With history of acute dysentery, likely diagnosis. So if there is a history of acute dysentery in the patient, following that, usually after 2 to 3 weeks, the patient presents to you with ascending bilateral symmetrical flaccid paralysis. The diagnosis is more likely to be GBS, that is Guillain-Barré syndrome. Important. याद रखना, if there is descending paralysis, you can think in terms of botulism, poliomyelitis or transverse myelitis. Descending paralysis होगा तो botulism, poliomyelitis, transverse myelitis. But if it is ascending paralysis, you will think in terms of ascending paralysis. Means the weakness starts from the legs, progresses to trunk, upper limbs, neck and face. This is called as ascending paralysis, and it is bilaterally symmetrical. ठीक है? So bilaterally symmetrical flaccid paraplegia following an episode of acute dysentery 2 to 3 weeks back. Diagnosis: Guillain-Barré syndrome. Now please tell me, flaccid paralysis means UMN lesion or LMN lesion? LMN lesion. But if they ask you which is the most common cranial nerve involved in Guillain-Barré syndrome, answer is 7th cranial nerve or your facial nerve. Bilateral facial palsy. So please remember, most common cranial nerve involved in Guillain-Barré. Most common cranial nerve involved in Guillain-Barré. Most common cranial nerve involved in Guillain-Barré. Which type of paralysis? Ascending or descending? Flaccid or spastic? Bilaterally symmetrical. ठीक है? Due to like a history of acute dysentery in the patient, and the organism causing it is known as Campylobacter jejuni. It can even be seen after COVID as EBV, okay, but mostly it is the organism known as Campylobacter jejuni infection. Now please tell me, investigation of choice would be, so why Guillain-Barré syndrome occurs? So there is autoantibodies. The phenomena which is seen in cases of Guillain-Barré syndrome is same as rheumatic fever, right? So the antibodies are produced in our body to attack the Campylobacter jejuni. But this organism, these antibodies will also attack our own myelin sheath, and therefore there is demyelination in this patient, right? There would be a demyelination, demyelinating polyneuropathy. What would be there? And these antibodies which are responsible for demyelination, these are anti-GM1 antibodies. The antibodies which are responsible are anti-GM1. Sometimes it can also be anti-GQ1 antibodies. Okay? So which antibodies are responsible for Guillain-Barré? Which antibodies? Anti-GM1 antibodies. What is the investigation of choice? That can be a pathognomic feature, but not the investigation of choice. Pathognomic है वो. So चलो वो पहले discuss कर लेता हूँ. We will perform, definitely a patient with paralysis comes to you. One of the things that you will perform is a lumbar puncture. Okay, and you will send the samples for CSF analysis. On CSF, everything would be normal except one factor, and that is protein. One factor is elevated, and that is so the cells are normal, but the proteins are highly elevated. Mainly the albumin is elevated. This is called as albuminocytological dissociation. This is called as albuminocytological dissociation. Important. Okay, so what is the feature of Guillain-Barré syndrome in CSF analysis? Albuminocytological dissociation. What is the investigation of choice? Still not. Demyelination है, क्या करोगे? MRI करोगे, ठीक है? Usually radiological investigation that we perform is MRI. More specific, if they ask you, definitely anti-GM1 antibodies can be seen. Pathognomic feature is definitely albuminocytological dissociation. Okay, it is there, but please remember that it can also be due to other features as well. ठीक है? Viral में भी कभी-कभी होता है, only proteins are elevated, rest is normal. So it cannot be so much diagnostic of Guillain-Barré. ठीक है? So clinical as well as lab diagnosis से तुम you will make a final diagnosis. Okay, usually investigation MRI क्यों है? Because you will see demyelination usually. ठीक है बस. Next is, and what is the treatment of choice? Drug of choice would be IVIG. Drug of choice would be intravenous immunoglobulin. Plasmapheresis can be performed as well, but the treatment of choice would always remain IVIG in the patient. Next question says a patient is brought with fever, headache, vomiting, neck stiffness. Neck stiffness is also known as nuchal rigidity. Present to the emergency room. History of seizure episode. So if there is seizure episode or altered sensorium in the patient, that means the infection is not only limited to the meninges, rather has also spread to the brain. Right? So it is a case of meningoencephalitis. encephalitis. It is a case of meningo. Okay, so please remember here the diagnosis would not only be meningitis but rather meningo. And this was a question which appeared in last December session. Okay? They also give features of seizure, along with that altered sensorium or altered behavior in the patient. That means there is brain involvement and the diagnosis becomes meningoencephalitis. What is the triad of meningitis, guys? Fever, headache, buccal rigidity. Triad of meningitis? Triad of meningitis? Along with that, definitely we can also find a projectile vomiting in this patient. Along with that, stupor, vagara, all of these features are seen. Here, diagnosis of meningoencephalitis definitely. Therefore, we have performed the EEG, electroencephalography, and that shows a that is periodic lateralized epileptiform discharge. And this periodic lateralized epileptiform discharge is due to a reason because the most common affected lobe would be the is the temporal lobe. Okay? And the most common cause for encephalitis or meningoencephalitis is anybody? Most common cause for encephalitis or meningoencephalitis? Viral. Which virus, please? HSV. Type 1 or type 2? Above which? Type 1. Okay. Most common cause of encephalitis? Most common cause of encephalitis? Most common cause of meningoencephalitis? HSV1. And therefore the drug of choice would be? Drug of choice would be? ये encephalitis समझ गए? That is, remember you, as the temporal lobe is involved, therefore EEG shows periodic lateralized epileptiform discharge. Moving up to meningitis now. Okay? So we have meningitis, this table, all of we have done in this one also. Test and discussion. So first of all, talking about few one-liners. Okay? Meningitis की अगर बात करें, inflammation of meninges, it can either be bacterial, tubercular, viral or fungal as well. ठीक है? Most common is acute bacterial meningitis. Now please tell me most common cause of bacterial meningitis? Streptococcus pneumoniae. Most common cause of bacterial meningitis? Most common cause of bacterial meningitis? Streptococcus pneumoniae. Important. Then most common cause of bacterial meningitis usually like between 2 to 20 years of age group. It is meningococcus. It is Neisseria meningitis. Okay, between 2 to 20 years of age group, adolescent patient, it is meningococcus. Okay, so to be specific, it is meningococcus. And as we know, in meningococcal meningitis, the patient will present with high-grade fever and a purpuric rash all over the body. Right? That is called as meningococcal meningitis. Important, please remember, meningococcal meningitis can damage the adrenal gland and there can be a sudden Addisonian crisis. This is called as which syndrome? Waterhouse-Friderichsen syndrome. So important complication of meningococcal meningitis is? Most important complication of meningococcal meningitis is? क्या हुआ? Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome. Waterhouse? It is associated with which type of meningitis? Meningococcal meningitis. And here we will have Addisonian crisis, deficiency of all adrenal hormones suddenly. Okay? No issues with this, I hope. Then neonatal meningitis, पीडिया के बता दो one-liners. Most common cause of neonatal meningitis. Most common cause of neonatal meningitis. Meningitis पूछ रहा हूँ मैं, meningitis. चलो. Most common cause of neonatal meningitis? Group B, Streptococcus. Most common cause of neonatal meningitis? Most common cause of neonatal meningitis? Most common cause of neonatal meningitis? Okay, worldwide I'm asking. Most common cause of neonatal meningitis in hospitals worldwide? Most common cause of neonatal meningitis in hospitals worldwide? Most common cause of neonatal meningitis in India? Usually Acinetobacter followed by Klebsiella. Most common cause of neonatal meningitis in India? Acinetobacter, if you have an option, so Acinetobacter followed by Klebsiella. No issues with this, everybody? Okay. So here bacterial meningitis, definitely the most common cause was pneumococcus or Streptococcus pneumoniae. Tubercular meningitis, please remember, it is definitely due to Mycobacterium TB. When there is dissemination of tuberculosis into the CNS, and when there is dissemination of TB into CNS, which type of focus is seen? Rich focus. Which focus is seen? CNS dissemination causes. CNS dissemination causes. Focus of TB have been asked in question, and ये तो सबसे easiest है. Disseminate bones focus is seen in lungs. Dissemination into CNS causes rich focus. Dissemination into CNS causes rich focus. Important. Next, if I talk about viral meningitis, most common cause of viral meningitis is encephalitis, HSV1. Meningitis it is most common cause of viral meningitis. Most common cause of viral meningitis. And most common cause of fungal meningitis. Most common cause of fungal meningitis. Cryptococcus neoformans. And as we know, cryptococcal meningitis is usually seen in which type of patient? Immunocompromised patients who are HIV positive. So in HIV positive patients, which type of meningitis is seen? Fungal cryptococcal meningitis. Jaldi se abhi. Okay, so a patient of meningitis comes to you. You have all that triad, that is fever, headache, and mucous rigidity. Projectile vomiting is also seen. Which two signs can be elicited? Kernighan, Bruzensky, Kernighan, and Brzezinski sign are positive in cases of meningitis. Then you will perform a lumbar puncture. Lumbar puncture is performed at which level? Lumbar puncture is performed at which level? L3, L4. Now this is a question हर जगह पूछा जाता है. Which is the first layer to pierce in lumbar puncture? First layer to pierce in lumbar puncture. Skin. First layer to pierce in lumbar puncture is skin. Then subcutaneous tissue. Then supraspinous ligament. Then interspinous ligament. Then which ligament? Ligamentum flavum. Which ligament? Ligamentum flavum. Then there would be dura mater. And then arachnoid matter. Arachnoid के आगे घुसोगे तो subarachnoid space में नहीं जाओगे. ठीक है? So the last layer to pierce is arachnoid matter. Last layer to pierce is this was a question which has been asked. Last layer to pierce in cases of lumbar puncture, it is your arachnoid matter. ठीक है? Now when we collect a CSF sample and send it for analysis, what are the features we'll see? ठीक है, so let's start again. So now please remember guys, jaldi se appearance of CSF in bacterial meningitis would be, in tubercular meningitis would be straw colored, and it would form a, so cobweb coagulum is formed in, cobweb coagulum is formed in, cobweb coagulum is formed in viral meningitis. It would be viral meningitis, it would be in fungal meningitis, it would be cloudy, it can be that turbid, हो सकता है straw colored, हो सकता है it can vary, so we will say straw colored again. ठीक है, so it is somewhat pale. Pressure now, if it is an infection, when we will insert the needle, so with which pressure CSF usually comes out, that is called as the opening pressure. So as all of them are infections, so opening pressure is increased in all types of meningitis. CSF pressure is increased in, again it is an infection and inflammation, so again everywhere the proteins would be, so proteins are also increased in, proteins are also increased in. Talking about cells, normally in CSF which type of cells are seen? Lymphocyte. Normally we have 0 to 4 lymphocytes. Normally we have 0 to 4 lymphocytes. But in cases of acute bacterial meningitis, we will find neutrophils, more than 1000 cells per cubic millimeter. So in acute bacterial meningitis, which cells are found? Apart from that, in all types we'll find, in all the other types we'll find lymphocytes. Jaldi se abhi, tubercular meningitis mein lymphocytes would be more than 100 cells. In tubercular, lymphocytes would be more than, in viral they would be more than 5 to 50, sorry, they would be around 50 to, in viral they would be around 50 to, and in fungal they would be around, in fungal meningitis they would be around, so jaldi se, more than 1000 neutrophils, more than 1000 neutrophils, 10 to 20 lymphocytes, 10 to 20 lymphocytes, more than 100 lymphocytes, more than 100 lymphocytes, 50 to 500 lymphocytes, 50 to 500 lymphocytes. Now talking about CSF glucose, which is normally 2/3 of the plasma glucose, right? So bacteria uses glucose, so CSF glucose will fall down in bacterial meningitis. TB is again a bacteria, so it will again decrease in cases of tubercular meningitis. Fungus also use glucose, therefore it will also be low in cases of fungal meningitis. But CSF glucose is normal in cases of, so fungal, CSF glucose is normal in cases of, CSF glucose is normal in cases of, CSF glucose is normal in cases of. Investigation of choice, jaldi se. For bacterial meningitis, we can do a polymerase chain reaction. We can do a polymerase chain reaction. If they ask you gold standard, then gold standard your best culture. Gold standard would be, and this PCR is actually done on the CSF sample. Then investigation of choice for tubercular meningitis, PCR. CB-NAT nahi karte hum. PCR is again done for Mycobacterium TB. Tubercular meningitis investigation of choice is, investigation of choice for tubercular meningitis is gene expert ऐसे या CB-NAT करा जा सकता है, but usually PCR is diagnostic, तो जरूरत नहीं पड़ती है. तो better we will go for simpler and inexpensive methods like PCR. ठीक है? So investigation of choice for tubercular meningitis, investigation of choice for viral meningitis, investigation of choice for viral meningitis, investigation of choice for fungal meningitis. ELISA. Investigation of choice for fungal meningitis is, investigation of choice for fungal meningitis is, but if ELISA is not an option as seen in cases of August 2020, so what would be your answer? Lateral flow assay. So investigation of choice in fungal meningitis, ELISA. Investigation of choice in fungal meningitis, investigation of choice in fungal meningitis, followed by, and here we will check for, cryptococcal antigen. Here we will check for cryptococcal. India in stain is definitely done for Cryptococcus neoformans, but it is not a rapid or not a very reliable test. Important. It is not a reliable test because it only stains the capsule of the organism. Okay, so yaad rakhna, India instinct should not be your answer. Investigation of choice would be ELISA for cryptococcal antigen followed by lateral flow assay for cryptococcal antigen. ये गलती आप करते हैं, don't take it हल्के में, ठीक है? ट्रीटमेंट क्या है अभी जल्दी से? acute bacterial meningitis, antibiotics like ceftriaxone plus vancomycin, ceftriaxone plus vancomycin plus. If it is listeria, we can add ampicillin. If the organism is listeria, we can add ampicillin. If it is pseudomonas, we can add meropenem. If it is pseudomonas, we will add meropenem. Then, in cases of tubercular meningitis, the treatment of choice would be anti-tubercular therapy. Along with that, we will give, why are steroids given? To decrease cerebral edema. Steroids are given to decrease. Treatment of choice for viral meningitis. Acyclovir. Treatment of choice for viral meningitis. 800 mg orally 5 for 5 days usually it is given. Drug of choice for fungal meningitis. Liposomal amphotericin B. So please remember, cryptococcal meningitis is a severe fungal infection. So for any severe fungal infection, drug of choice is liposomal amphotericin B. Drug of choice for cryptococcal meningitis. Liposomal amphotericin B. Lamb is also a drug of choice for Kala Azar. Lamb is also a drug of choice for mucormycosis. Lamb is also a drug of choice for. All of these are severe fungal infections. एक फंडा याद रखो, severe fungal infection drug of choice is lamb. Along with that, we give 5-flucytosine. No issue with this. Everybody, meningitis समझा, repeat करना है जल्दी. जरूरत है या नहीं है? पता है, जल्दी जाने दो. Next, now talking about intracranial hemorrhages. If I talk about intracranial hemorrhages, when a patient presents to you after a road traffic accident or trauma usually, okay? The first investigation or the best investigation that we do, it is a NCCT head. The best investigation for trauma would be NCCT head. Now on NCCT head, I hope all of you are quite aware. If on CT we find something whitish opacity, it is called as hyperdensity. And if we find some blackish decency, it is called as hypodensity, right? So here, if I find this kind of opacity, a biconvex opacity suggests your extradural hemorrhage. So EDH में किस type की opacity? After trauma, the patient was unconscious, then gained consciousness, and then again went unconscious. This is known as the lucid interval is a feature of EDH. Next, for EDH, the most common vessel to be ruptured is MMA. Most common vessel ruptured in EDH is middle meningeal artery. What is the landmark for this middle meningeal artery? Landmark for middle meningeal artery. Therefore, if in patients of EDH we need to perform a decompressive surgery, that is called as which surgery is performed? So that Burhoff surgery for that landmark would be, for Burhoff surgery landmark is, no issues with this. Moving further to our next one. If on the NCCT head, you can get this type of opacity, that is a concavo-convex opacity. Concavo-convex opacity or half moon shaped or crescent shaped opacity. This is suggestive of subdural hemorrhage. Now, most of the time people say कि concavo-convex opacity समझ में नहीं आती. Yes, I have also experienced it myself. August में we were not able to recognize what it was, whether a concavo-convex or not. So please remember, the other feature you will be able to visualize is the midline shift. So the ventricles would be pushed towards the other side. So midline shift. Along with concavo-convex opacity, you will get a midline shift. So these two important NCCT features. They are seen in cases of which type of hemorrhage? Subdural hemorrhage may be the history. There would be of a trauma, bike accident, or a history of fall. Classical case would be 60-year-old male brought to you after a history of fall 7 days ago, now complains of headache. Okay? So please remember, in ADH, the patient is brought to an emergency, but in HDH, usually there would be a mild trauma to the patient, and it is mostly seen in extremes of ages. What do we mean by extremes of ages? It is more common in children and elderly. More common in children and elderly, and so in extremes of ages, this is more common. It is due to mild trauma. There would be a history of slip in the bathroom. Most characteristic case आता है ये HDH का, and the patient will only complain of headache, no other neurological deficit. ठीक है? So what is the treatment of choice for HDH? Anybody? Treatment of choice for HDH. Did I say the patient of HDH is having any raised ICP features? No. So if the patient is not having raised ICP features, the treatment of choice would be observation and monitoring. In HDH, the treatment of choice would be observation and monitoring. If the patient has raised ICP features means DHC. DHC क्या क्या था? 3 triad of raised ICP. D for bradycardia. B for H for hypertension. H for C for Cheyne-Stokes breathing. C for so raised ICP का triad. B for H for C for. So if any of these features of raised ICP are present, then definitely we will give IV mannitol in the patient, right? And it is usually given after some time, not in active hemorrhage. Otherwise, that will cause brain herniation. Okay? Most common vessel ruptured in HDH is, those are your cortical bridging emissary veins. Those are your cortical bridging emissary veins. So only venous intracranial hemorrhages, HDH. Only venous intracranial hemorrhages. All others are arterial hemorrhages. Next, if I talk about this, here you can see a NCCT guide. Here you cannot find anything abnormal most of the time, but only in the ventricles. Ventricles usually contain CSF, so they would be black in color. But if the ventricles or the Sylvian fissure, okay, in the ventricles or the Sylvian fissure, you can find opacity. That means they are containing blood. This is suggestive of subarachnoid hemorrhage. This is suggestive of. Here also the history of trauma can be there. The most common cause would be rupture of. Most common cause would be rupture of. And barrier aneurysms are commonly seen in which artery? Barrier aneurysms, small aneurysms are seen in anterior communicating artery. Barrier aneurysms are commonly seen in. And barrier aneurysm rupture leads to which type of hemorrhage? And in subarachnoid hemorrhage, opacity would be seen in ventricles and Sylvian fissure. Sylvian fissure, and the most common complaint would be thunderclap headache or worst headache of my life. This is the key word. So if the patient says there is a thunderclap headache or worst headache of my life, the diagnosis is more likely to be subarachnoid hemorrhage. And what is the drug of choice for subarachnoid hemorrhage? IV nimodipine. IV nimodipine. Last type of hemorrhage, here you can see there is hemorrhage or opacity in the brain parenchyma or in the brain tissue, right? Along with that, midline shift is also seen over here. Okay? So if the opacity is in the brain tissue along with the midline shift, then it is a case of intracerebral hemorrhage, right? And intracerebral hemorrhage, the most common site vessel ruptured is Charcot's artery. Most common vessel ruptured is Charcot's artery is also known as lenticulostriate artery. It supplies the basal ganglia, and the most common part affected is actually your putamen. So intracerebral hemorrhage is usually seen in which age group? Elderly patients. Intracerebral hemorrhage is commonly seen due to hypertension. Intracerebral hemorrhage is common in elderly patients due to malignant or hypertensive crisis in the patient. Okay? There would be rupture of this artery. What is the drug of choice in intracerebral hemorrhage? IV nicardipine. IV. How to remember? C for C. Okay? No issues with this. Moving to important, and that is CVA, cerebrovascular accident. A patient comes to the ER with right-sided weakness, okay, and facial numbness. One half of the weakness, paresthesia, paraplegia, sorry, one-sided weakness, one-sided paralysis is called as hemiplegia. This is called as both lower limbs में weakness हो तो paraplegia. Both lower limbs में weakness हो तो half side of body में हो तो चारों limbs में हो तो quadriplegia. ठीक है? So here the patient is coming to you with right-sided hemiplegia along with facial numbness. NCCT head is given. Here you can see on the NCCT, you can see opacity or a lucency, hyperdensity or hypodensity. Here you can see a hypodensity in the patient, right? So hypodensity is usually seen in this area, right, on the left cerebral hemisphere. So as the lesion is on the left cerebral hemisphere, there will be a right-sided weakness due to cross innervation. Right-sided brain controls left part of the body, and left-sided brain controls. Okay, so here if the patient is having right-sided weakness, the patient will have finding on the left side of the CT scan. Here you can see a left-sided lucency, and it is most likely due to which type of stroke? Hemorrhagic or ischemic? So please remember, in hemorrhagic stroke, as we saw, there would be a hyperdensity or a whitish opacity. But in ischemic stroke, there would be a hypodensity or a lucency which is seen. So CVS can either be ischemic stroke or a hemorrhagic stroke. Most common is out of ischemic. It has embolic stroke and thrombotic stroke. Most common is. So most common type of stroke overall. Most common type of ischemic stroke. Both of them are an option. What you do mark? Embolic, because it is more specific. Okay, it is embolic. Most common overall. Okay, 80%. Yes, almost. So in ischemic stroke, we saw on NCCT head, we will find hypodensity or a lucency in the patient. Now, according to the lobe which is involved, there would be symptoms. Okay, so please tell me if this is the motor homunculus, guys. I hope all of you are quite aware of the motor homunculus. So the part of the brain or the part of the motor cortex which is responsible for organs. Okay, so anteriorly it is the leg, followed by your arm, followed by your face. Okay, then your tongue, and lastly your larynx. Okay, so please remember, if there is anterior cerebral artery blockage, it will lead to, there would be weakness, yes, both in arms as well as legs, but more in the here you can see the reason. Okay, so please remember, weakness in legs more than arms is feature of anterior cerebral artery stroke. Weakness in legs more than arms is a feature of, if there is MCA artery damage or MCA artery blockage, there would be dense hemiplegia. There would be loss of all sensations, there would be a complete weakness on one half of the body, because middle cerebral artery usually supplies the middle part of the brain, and that contains the internal capsule. So if internal capsule is damaged, there would be a dense hemiplegia in the patient. If internal capsule is damaged, that will cause dense hemiplegia. And dense hemiplegia is caused by blockage of. Apart from this, guys, if there is a posterior cerebral artery damage, that will lead to homonymous hemianopia and visual hallucination. Posterior cerebral artery damage can lead to homonymous hemianopia and visual hallucinations usually. ठीक है, याद रखना. Now, if the frontal lobe is damaged, it will lead to. If the frontal lobe is damaged, it will cause loss of personality. There would be loss of personality, and there would be a anti-social behavior. So usually this person will behave like an alcoholic. Okay, so antisocial behavior is due to damage to the short-term memory loss is due to damage to the temporal lobe. If there is damage to temporal lobe, there can be motor aphasia or sensory aphasia. Sensory aphasia, because which part is damaged? Wernicke's area. Which part is damaged? And Wernicke's area causes sensory aphasia. Wernicke's area causes Broca's area causes motor aphasia. Broca's area causes, and Broca's area is present in the frontal lobe. Wernicke's area is present in the temporal lobe. Apart from that, in temporal lobe damage, the patient would not be able to recognize familiar faces. This is called as prosopagnosia, inability to recognize familiar faces. One-liner recall question. Prosopagnosia, inability to recognize familiar faces is called as prosopagnosia. Due to damage to which part? Temporal lobe. If there is damage to the parietal lobe, the higher mental functions would be lost. There would be apraxia, there would be agraphia, there would be aphasia, there would be calculia. So all these and dyslexia, all of these higher mental functions are lost due to damage to short-term memory loss, prosopagnosia, temporal lobe, antisocial behavior, visual hallucinations, homonymous hemianopia, occipital lobe. ठीक है, lobe symptoms समझ में आ गए. So usually, and if there is anterior cerebral artery damage, usually there would be frontal lobe symptoms. If there is middle cerebral artery damage, there would be parieto-temporal lobe symptoms. ठीक है, both of them. And if there is a posterior cerebral artery blockage, there would be occipital lobe symptoms. No issues with this. Now, please tell me what is the treatment of choice in cases of ischemic stroke. We have discussed about hemorrhagic stroke now. Treatment of choice for ischemic stroke. चलो वो बता देता हूँ. If symptoms of stroke are usually lasting for less than 24 hours, it is called as transient ischemic attack. Symptoms lasting for less than 24 hours, it is transient ischemic attack. It will resolve by itself. ठीक है, it will be a very small blockage or a very small hemorrhage. ठीक है, so symptoms for less than 24 hours, transient ischemic attack. Symptoms for more than 24 hours, stroke. Most common ischemic. Most common subtype embolic. And where from this embolus comes from? Atrial fibrillation. Most common cause of embolic stroke is there would be clots which would be formed and which will dislodge and cause embolus. ठीक है? Treatment of choice in cases of ischemic stroke. If the patient presents to you within 4.5 hours, you will do thrombolysis. And thrombolysis के लिए it is done with recombinant tissue plasminogen activator like altiplase, retiplase. Retiplase is preferred. ठीक है? So if a patient presents to you within 4.5 hours of symptom onset, treatment of choice is within 4.5 hours, after 4.5 hours, observation and monitoring is done. Then treatment of choice for transient ischemic attack. Dual antiplatelet therapy. Treatment of choice for transient ischemic attack. Dual antiplatelet therapy contains aspirin and clopidogrel. These are also given in cases of MI, myocardial infarction. ठीक है? So याद रखना, if a patient of ischemic stroke within 4.5 hours, thrombolysis. After 4.5 hours, TP. याद रखना, in cases of hemorrhagic stroke, definitely we will give antihypertensive drugs. But in cases of ischemic stroke, antihypertensive drugs are only and only given when the BP crosses 185/110. Otherwise, we will keep BP on the higher side because we want to maintain the cerebral perfusion pressure. ठीक है? So usually, please remember, this is the trick they play in neurology questions, CVA के questions में. Okay, they will ask you the first line management. If the patient presents within 4.5 hours, thrombolysis. After 4.5 hours, observation and monitoring. Though the BP is around 160/100, you don't need to do anything to the BP. Okay? If the BP surpasses more than 185/110, then the drug of choice would be hypertensive crisis. Drug of choice is nicardipine. Drug of choice is sodium nitroprusside can also be given, but nicardipine is preferred in hemorrhage. Okay? Or like in cases of neurological hypertension. No issues with this. Hypertension से याद रखना, don't mark it. If the blood pressure is less than 185/110, don't mark antihypertensives as your answer. It should always and always be thrombolysis or observation. ठीक है? Moving further. Tumors जल्दी से. Most common brain tumor, anybody? Most common brain tumor? Metastasis. Most common brain tumor? Metastasis or secondaries. Most common primary responsible for brain met? Right, it is the old cell carcinoma, that is lung cancer, followed by breast cancer. So most common malignancy causing brain met? Most common malignancy causing brain met? Most common malignancy causing brain met? Old cell carcinoma of lung. Then if I ask you, most common primary brain malignancy. Most common primary brain malignancy in adults. In adults, a high-grade astrocytoma or high-grade glioma known as glioblastoma multiforme. Whereas most common primary malignancy in children. In children it is medulloblastoma. Now benign tumor jaldi se. Most common primary benign tumor in adults. 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 Meningioma followed by astrocytoma. And most common primary benign tumor in children. Craniopharyngioma. Most common primary benign tumor in children. Children में benign. Children में benign. Children में malignant. Children में malignancy. Children में malignancy. Adults में benign. Adults में benign. Adults में malignancy. Adults में malignancy. Overall most common. No issues with this. Now, if I say a tumor is arising from the meninges, okay, on NCCT head it appears to be white. Why? Because there would be calcification. There would be, and if I perform a biopsy, in this I can find concentric lamellated calcification. These are called as concentric lamellated calcifications are called as concentric lamellated calcifications are called as. Some of our bodies are seen in PSN. P for capillary carcinoma of thyroid and capillary renal carcinoma. S for serous cyst adenoma and M for meningioma and mesothelioma. Meningioma and ठीक है याद रखना. So if it's samoma bodies, this was a question which has been repeated twice in the recent pattern. ठीक है. So they have given you NCCT and the tumor was arising from the meninges. It was a calcified tumor, so appeared white. Okay, and biopsy was showing samoma bodies. So the diagnosis would be most common benign brain tumor in adults, that is diagnosis would be meningioma. No issues with this. Next, here I can see the cells usually, please remember the cells are having a central nucleus with a perinuclear halo. So they are giving a characteristic appearance known as fried egg cell. So fried egg cell appearance is seen in oligodendroglioma. And in between cells, the capillaries are resembling the chicken wire. So chicken wire capillaries are again seen in cases of oligodendroglioma. So the diagnosis in this condition is so jaldi se biopsy feature of meningioma. Biopsy feature of meningioma. Biopsy feature of oligodendroglioma. Which type of cell? Which type of cell? Which type of capillary? Which type of capillary? Please remember, oligodendroglioma is also a calcified brain tumor. It is rather the most common calcified brain tumor. No issues with this. Next, if I have a brain tumor which is going in both the cerebral hemispheres and resembling a butterfly, so this is called as a butterfly tumor. And on biopsy, I can see this type of necrosis. This is called as palisading, serpentine, or garland necrosis. Which type of necrosis? Which type of necrosis? Which type of necrosis? Sorry, garland necrosis. ठीक है, वो भी थक गया अभी. So palisading or garland necrosis and butterfly tumor. These are features of glioblastoma multiforme. And glioblastoma multiforme has the worst prognosis. So worst prognosis among brain tumors is seen with glioblastoma multiforme is which kind of a tumor? Butterfly tumor. And which type of biopsy feature is seen? Palisading or a no issues with this. Moving further. ये मैं patho भी cover कर रहा हूँ. That is why it is scientific. Next, please remember here you can see the cells, malignant cells are arranged in a rose petal-like fashion. Therefore, these are called as rosettes. Here you can see these are called as Flexner-Wintersteiner rosettes. These are called as and Flexner-Wintersteiner rosettes are seen in whereas these are called as Homer-Wright rosettes. And Homer-Wright rosettes are a feature of Homer-Wright rosettes are seen in Flexner-Wintersteiner rosettes are seen in one more type of rosette. True rosettes are usually seen in cases of ependymomas as well. Okay? Now, next one. Here you can see there is a calcified tumor, but this calcified tumor is usually arising above the sella turcica. So this is actually a supracellular tumor. So this is a supracellular tumor which is calcified, and it is more common in which age group? More common in children. Most common benign brain tumor in children. The answer is so here the diagnosis would be most common benign brain tumor in children is craniopharyngioma. It would be a calcified brain tumor. So here you can see on MRI, usually there would be calcification which is seen above the sella turcica or near the pituitary gland. And therefore craniopharyngioma, as it is near to the optic chiasma, it can compress optic chiasma and lead to so bitemporal hemianopia is caused by which brain tumor? Whereas overall, most common bitemporal hemianopia is caused by it is caused by pituitary. Which type of pituitary adenoma? Prolactinoma. Which type of pituitary adenoma? So there was a case where they have given the patient is suffering from bitemporal hemianopia along with features of galactorrhea and amenorrhea. Diagnosis would be pituitary adenoma and not craniopharyngioma. In craniopharyngioma, the other features of galactorrhea and amenorrhea would not be seen. So this was the diagnosis you need to remember. Okay, no issues with this. And biopsy of craniopharyngioma will show what? Wet keratin. Biopsy of craniopharyngioma shows or motor oil-like substance. Okay? No issues with this. Now, if I give you this type of a picture, this is the NCCT head, and you can see there are some tuberous growth arising in the cortex. So these are called as cortical tubers. And the mass arising from the ependymal cells in the ventricles. These are called as subependymal astrocytoma. These are seen in cases of the diagnosis over here is it is a neurocutaneous syndrome known as. Along with this, there would be these acne-like growth usually. These acne-like growth on the face are called as adenoma sebaceum. The patient presents to you with focal seizures. Abhi to bata do. Epiloia is the diagnosis. Epiloia is the mnemonic triad. Epi for epilepsy means partial. Usually focal seizures in the patient. Lo for low IQ, that means mental retardation. And A for this adenoma sebaceum. Ab diagnosis neurocutaneous syndrome known as tuberous sclerosis. The diagnosis is so in tuberous sclerosis, what would be seen on the face? On face you will find which type of seizures are seen? Focal seizures. Which type of seizures are seen? And on NCCT head, in the cortex we will find cortical tuber. Cortex we will find, and in the ventricles we will find subependymal astrocytoma. If they ask you the most common or the earliest feature of tuberous sclerosis, answer would be these hypopigmented macules on the trunk, these are called as Ashreef macules. These are called as, so hypopigmented macules on the trunk in a patient of tuberous sclerosis are called as, most common feature of tuberous sclerosis is, earliest feature of tuberous sclerosis is Ashreef macules. Then there would be an irregular skin or orange peel-like appearance. This is called as Sjogren's patch. This is called as, and this was the image which came earlier. At the nail bed, there is an overgrowth which is seen. This is called as a subungual fibroma. This is called as a, and subungual fibroma is also known as which tumor? Cohen's tumor. Subungual fibroma is also called as which tumor? Subungual fibroma is also called as which tumor? So jaldi se, tuberous sclerosis jaldi in short time. Epiloia is the triad. Epi for epilepsy. LO for low IQ, that is A for adenoma sedation. Most common and earliest feature Ashreef macule. Orange peel-like consistency and subungual fibroma known as, in brain which type of tumor? Subependymal astrocytoma. And focal seizures would be there. In kidney, and usually they will ask you in heart. In kidney, which type of tumor is seen? Angiomyolipoma. In kidney we will find, and in heart we will find rhabdomyosarcoma. In heart we will find, okay, rhabdomyoma would be there, more common. Okay? The drug of choice for tuberous sclerosis. So again, it is a genetic condition due to TSC1 and TSC2 gene mutation. Drug of choice for partial seizures, yeah, focal seizures, carbamazepine. So drug of choice would be carbamazepine. ठीक है, याद रख लेना. No issues with this. Next, here you can say these outgrowths usually on the trunk. These are called as neurofibromas. And in neurofibromatosis, the most common or the earliest region which is seen is these. These are hyperpigmented macules on the trunk, known as Capiolia macules. Which macules? Most common region in neurofibromatosis is, and how many of them are diagnostic? Your question tha. More than six are diagnostic of neurofibromatosis. Neurofibromatosis is type 1 and type 2. NF1 gene is located on chromosome number, सब बोल लो. NF1 gene on chromosome number, NF2 gene on chromosome number, NF1 on, NF2 on. ठीक है. NF1 is associated with which type of tumor? NF1 is associated with, these are the questions. ठीक है. Whereas NF2 is associated with, एक तो meningioma, and the most common would be a cerebellopontine angle tumor, bilateral, 8 cranial nerve tumor known as acoustic neuroma, also called as vestibular schwannoma. So there would be a bilateral acoustic neuroma. ENT is an important question. Please remember, NF2 is associated with which two tumors? Meningioma and acoustic neuroma. NF2 is associated with which two tumors? Meningioma and acoustic neuroma. And NF1 is associated with optic glioma. Okay, no issues with this. Important है, ये questions पूछे गए. If a patient of bilateral acoustic neuroma comes to you with hearing loss, what would be your treatment of choice? ENT. Right. Cochlear implant surgery करोगे या नहीं करोगे ये तो बता दो. Cochlear implant surgery cannot be performed. All of us mark cochlear implant surgery. It is a wrong statement. For cochlear implant surgery, 8 nerve should be intact. Here 8 nerve is damaged. So in cases of bilateral acoustic neuroma, auditory brainstem implant is the choice. What is the choice? Question has been repeated, so I have asked you. Okay? इसी तरीके को बोलते हैं integrated fashion में पढ़ना. तो अगर यहाँ पे अगर आया है ENT का क्वेश्चन, तो यहाँ पे करके छोड़ेंगे उसको याद. ठीक है? ENT में जाकर रिवाइज ही होगा वो. Next, most characteristic if they ask you, most characteristic feature. Here we can see our axillary freckling. What is seen? So most characteristic region of neurofibromatosis, most characteristic feature of neurofibromatosis, most common, क्या कहोगे यहाँ पे? Most common, most characteristic, and here we can see iris hamartomas usually, and these iris hamartomas are called as iris hamartomas in neurofibromatosis are called as Lesch nodules. ठीक है, बहुत ज्यादा है, but I'll take a pause. शायद बाकी मैं डिस्कस नहीं करूंगा, फिर I'll discuss in the next class. ठीक है, चलेगा? So यहाँ पे ये डिस्कस करके जो neurocutaneous syndrome. Next one. This here you can see the patient is having a pinkish lesion on half of the face. This is due to a cavernous angioma, and it is called as which stain? Port wine stain. It is called as which stain? Port wine stain. Okay, it is called as a port wine stain. In this video also you can see, right? This diagnosis would be diagnosis is Sturge-Weber syndrome. In Sturge-Weber syndrome also the patient will suffer from. In Sturge-Weber syndrome the patient will suffer from, and therefore the drug of choice would be carbamazepine. On NCCT head we will find which appearance? Tram track appearance. NCCT head we will find which appearance? NCCT head of Sturge-Weber shows which appearance? Jaldi. Tram track. Tram track on chest X-ray? Bronchiectasis. Tram track on chest X-ray? Tram track on kidney biopsy? Tram track on kidney biopsy? क्या बोले तुम? Tram track on kidney biopsy? MPGM. Tram track on kidney biopsy? Tram track on kidney biopsy? Tram track on NCCT head? Sturge-Weber. Tram track on NCCT head? याद रखना. So here the patient will have focal seizures. There would be cavernous angioma known as port wine stain. There would be a tram track appearance, and along with that there would be a high risk to develop glaucoma in the patient, right? There would be a risk of glaucoma in this patient, right? So this is what is a Sturge-Weber syndrome. And lastly, I'll only discuss about this. Here you are getting an intracranial space occupying lesion, and the most common intracranial space occupying lesion in a patient of HIV, and the patient will present to you with seizures. What is the diagnosis? Most common intracranial space occupying lesion in a patient of HIV, along with seizures. Here you can see a calcified lesion. The diagnosis is cerebral toxoplasmosis. Diagnosis is. So most common ICSOL in cases of HIV patient is cerebral toxoplasmosis. Cerebral toxoplasmosis is caused by organism known as Toxoplasma gondii. Organism known as Toxoplasma. It is not Cryptococcus neoformans. Cryptococcus neoformans causes meningitis and not an intracranial space occupying lesion. Intracranial space occupying lesion in HIV causing seizures is only and only cerebral toxoplasmosis. It is seen when the CD4 count goes below 200. So CD4 count below 200, or sometimes some books mention CD4 count below 100. Okay? So please remember, neurotoxoplasmosis is seen when the CD4 count is less than. When does the risk of opportunistic infection in patients of HIV increase? CD4 count less than. Opportunistic infections की risk कब बढ़ती है in a patient of HIV? CD4 count less than 500. CD4 count less than 500. And the most common opportunistic infection in a patient of HIV. Overall पूछा ना मैंने कुछ बोला. Most common opportunistic infection in HIV positive individual. It is Pneumocystis jirovecii pneumonia. Pneumocystis jirovecii or Pneumocystis carni pneumonia. If I say most common opportunistic infection in Indian HIV positive patient, answer would be tuberculosis. Both are seen in usually Pneumocystis jirovecii is seen when CD4 count is less than 200, and TB is seen when the CD4 count is less than 500. Okay, important. Which is the most common brain tumor in patients of HIV or tumor overall? Which is the most common tumor in a patient of HIV? Kaposi sarcoma, right? No? Most common tumor in a patient of HIV. HIV के patient में most common tumor non-Hodgkin lymphoma. Most common tumor in a patient of HIV is most common tumor in a patient of HIV is non-Hodgkin lymphoma with subtype diffuse large B cell type. ठीक है. Second most common is Kaposi sarcoma. बहुत लोग Kaposi sarcoma अभी भी मार्क कर रहे हैं. Please remember the most common one is non-Hodgkin lymphoma, whether brain or any other organ in HIV patient. ठीक है. Meningitis की cause Cryptococcus neoformans. Intracranial source pre-occipient lesion. Cerebral toxoplasmosis. The most common opportunistic worldwide, pneumocystis jirovecii. Most common opportunistic India, TB in the patient. No issues. CD4 count less than 50. मैक हो सकता है और CMV रेटिनाइटिस भी हो सकता है. इंपॉर्टेंट. ठीक है. ये हो गया तुम्हारा HIV के बारे में. Most characteristic feature in HIV, like HIV dissemination into CNS. When HIV disseminates into CNS, most characteristic feature is microglial nodules. What is the most characteristic feature? Most characteristic feature in HIV, in brain it is microglial nodules. Okay. And they would be most common, if they ask you symptom, then it would be dementia in the patient. Here you can see which type of appearance. NCCT head. NCCT head is showing a lot of calcified small lesions. This is giving which appearance? Which appearance? Starry's appearance is seen in case of neurocystic sarcosis. Neurocystic sarcosis is caused by which organism? Neurocystic. It is Taenia saginata or Taenia solium. Important. Please remember, Taenia solium causes neurocystic sarcosis. Taenia saginata cannot cause neurocystic sarcosis. याद रखना. ठीक है. CNS dissemination is seen with Taenia solium. It is due to ingestion or intake of uncooked pork. Okay, uncooked pork or sometimes contaminated vegetables as well. ठीक है. So important. With Taenia solium feces. ठीक है. So Taenia solium can cause neurocystic sarcosis. Appearance is Starry's appearance. Drug of choice would be for systemic infection it is praziquantel. For CNS infection it is albendazole 400 mg. ठीक है. याद रखना. Drug of choice for neurocystic sarcosis. Drug of choice for neurocystic sarcosis. With this I complete the session for today. We'll discuss some parts of neurology. That is pharma has been left, and then I'll start with pulmonology and rheumatology in the next class. ठीक है. So याद रखना nephro was important from patho इसलिए deep में लिया. Neuro तुम पढ़ते नहीं हो इसलिए deep में लेना पड़ रहा है. बाकी systems short में लूंगा. Cardio पे ज़्यादा focus रहेगा मेरा. ठीक है. Medicine है. Be ready. If you want कि short notes होंगे तो नहीं हो सकते guys. I'm trying my best to narrow down the notes as much as possible, but इससे कम medicine नहीं हो सकता है. ठीक है. कम से कम इतना पढ़ लो. ठीक है. Important from medicine are definitely cardio and pulmo. Major bulk cardio and pulmo होता है, followed by electrolyte and EBG. उसके बाद बाकी systems आती है. But neuro से हमेशा 3-4 questions तो होते हैं minimum. ठीक है. And neuro also helps you in ophtha वगैरह बाकी इसमें भी help करता है, so it is important as well. So let's discuss about neurology, right? A patient, question says a patient presents with progressive loss of vision and paresthesias in the limbs along with electric shock sensation or neck movement. Diagnosis is what in this condition, anybody? So there is progressive vision loss. If I talk about the fundoscopic examination of this patient, I will find inflammation of the optic disc. And inflammation of optic disc is called as papillitis. Inflammation of optic disc is called as. So the patient can have papillitis, the patient can have neuroretinitis or retrobulbar neuritis. Any of these features can be present. That is suggestive inflammation of your second cranial nerve. That means optic nerve. So the patient will have a feature of optic neuritis. Along with that, the patient also has complaints of paresthesia or loss of sensations, usually in the limbs, right? So loss of sensations in the limbs. Along with that, they have mentioned the patient has electric shock sensation on neck movement. So when there is neck movement, the patient has a very severe or excruciating pain in the lower limb, just like he is receiving some electric shock. This is called as this sign. Very good. This is called as the Lermit sign. This is known as the Lermit sign, right? Apart from this, a characteristic thing that they mention in question is pin and needle sensation. Okay, the patient will feel pin and needle sensation. All of these are in favor of multiple sclerosis. The diagnosis in this condition would be multiple sclerosis. So important. Paresthesia along with which type of sensation? Pin and needle sensation. Fundoscopy shows optic neuritis. Important. And electric shock sensation on neck movement is known as Lermit sign. All of these features are seen in multiple sclerosis. Okay, by the name itself, you can know multiple sclerosis means here multiple cranial nerves would be damaged. Okay, important thing. Apart from that, it is a demyelinating condition, right? There would be loss of the myelin sheath, and that causes the inflammation of your nerve. Okay. What is the investigation of choice? Anybody? Gadolinium enhanced MRI. Investigation of choice for multiple sclerosis is investigation of choice for multiple sclerosis is and gadolinium enhanced MRI. What happens usually? There will be formation of plaques. So please remember, now as there is damage to the nerves on one side, on the other side there would also be repair of these nerves. Okay, the repair of nerves is actually called as gliosis. Repair of the nerves is called as gliosis. Due to this gliosis, there would be formation of these plaques, okay, in the periventricular region, and these on MRI are called as Dawson figures. These are called as Dawson figures. No issue. So investigation of choice for multiple sclerosis. Investigation of choice for multiple sclerosis. On MRI, what will we find? We will find Dawson's figures, and Dawson's figures are due to gliosis. Important. Now they have also asked, apart from the diagnosis, which are the cells damaged in cases of multiple sclerosis? Which are the cells which are damaged? So I hope all of you are quite aware. In the nervous system, we have the main functional unit, that is your neuron, and some accessory cells. So the accessory cells, these can be astrocytes. Astrocytes are responsible for wound healing and repair. Astrocytes are responsible for okay, and they also lead to formation of the blood-brain barrier. Astrocytes also form the right. Next, second cells are oligodendrocytes, and these oligodendrocytes are responsible for myelination within CNS or outside CNS? Within CNS. So within CNS, myelination is due to outside CNS, myelination is due to Schwann. Outside CNS, myelination is due to all of these are one line. Okay. Within CNS myelination, outside CNS myelination, Schwann. And the last type of cells usually, okay, which are mesodermal in origin. All of these are mesodermal in origin. They will line the ventricles, and the cells which line the ventricles are called as ependymal cells. Cells which line the ventricles are called as ependymal cells. And one of the cells are definitely, sorry, these are neuroectodermal in origin. One of the cells are mesodermal in origin, M for M. So mesodermal cells are usually microglia, and microglia are also called as jitter cells or Ortega cells. Microglia are also called as jitter cells or Ortega cells, and they are brain macrophages. Microglia are brain macrophages are liver macrophages are Kupffer cells. Liver macrophages are Kupffer cells. Placental macrophages are Hoffberg cells. Placental macrophages are splenic macrophages are littoral cells. Splenic macrophages are littoral cells. Kidney macrophages are mesangial cells. Kidney macrophages are mesangial cells. So among all these, as I told you, multiple sclerosis is a demyelinating disorder. So which type of the cells would be damaged? So oligodendrocytes. So the cells damaged in cases of multiple sclerosis are, and therefore there would be demyelination in the patient, which causes paresthesia, loss of sensation, and the Lermit sign in the patient. Along with that, there would be optic neuritis. What is the drug of choice? Anybody? The drugs which are usually given for multiple sclerosis. Investigation bata diya. Previously, we used to use beta interferon, but nowadays we prefer using glatiramer acetate. We prefer using glatiramer acetate. And the second drug is a monoclonal antibody known as metalizumab. Second drug is important. The drugs used in cases of multiple sclerosis. First is glatiramer. First is. Second is. समझ गया multiple sclerosis. इतना याद रख लो, important. Moving further. Then if I take a biopsy of the brain, and in biopsy of the brain, I can find the neuron which has a very eosinophilic cytoplasm or a very bright red cytoplasm. These are called as red neurons. And red neurons are seen due to hypoxia. So red neurons are due to hypoxia. Red neurons are due to hypoxia. And in gliosis or astrocytoma, जो तुम बोल रहे हो, in gliosis which type of cells would we see? In gliosis we will find important. समझ गए? जल्दी से. Hypoxia causes gliosis leads to causes Rosenthal fibers. Important cells याद रख लो, pathology important. Moving further, inclusion body important. First inclusion body, a boy had a dog bite, and after that, on examination, after his death, on examination in the neuron, we can see a densely eosinophilic cytoplasmic body. This is called as the and Negri bodies are seen in cases of. So these are intranuclear or intracytoplasmic. These are intra. Negri bodies are intra. Cytoplasmic eosinophilic bodies. No issues with this. Speed of virus in rabies. Previous year question. एक आंसर करना हो, क्या करोगे? Based on the bite, but एक आंसर करना हो. Speed of virus in rabies in the nerve. ये तो कर दो. 3 mm per day, yeah, 3 mm per. It is 3 mm per hour. So speed of rabies virus in nerve there. This was a recall question, important. Okay. So what is the most pathognomic feature of rabies, guys? Most pathognomic feature of rabies. It is hydrophobia. So most pathognomic feature of rabies is. Okay. Important microbes outside discuss करते चलेंगे. जहाँ important. Next, here you can see these ones. Here you can see some intranuclear inclusion bodies, and these are densely basophilic. These resemble which. These give a owl-eye appearance. So owl-eye inclusion bodies are seen in. Cytomegalovirus infection. Cytomegalovirus is HHV, human herpes virus type 5. Cytomegalovirus is human herpes virus type. It can lead to infectious mononucleosis like the syndrome. Infectious mononucleosis is caused by Epstein-Barr virus. Infectious mononucleosis like syndrome by. And which type of inclusion body? Owl-eye inclusion body. Basophilic intranuclear inclusion body. These will resemble which cells? Owl-eye inclusion bodies resemble which cells? Reed-Sternberg cells or the RS cells. And Reed-Sternberg cells are seen in Hodgkin sarcoma. No issues with this. Moving further. Next, here you can see these are not inclusion bodies, rather giant cells. These multinucleated giant cells are called as Warthin-Finkelday giant cells. These multinucleated giant cells are called as, and these Warthin-Finkelday giant cells are seen in measles, right? So measles, there will be erythematous rash all over the body in the patient along with fever. Most common complication of measles virus. Most common otitis media. Most common complication of measles. Otitis media. Rare and a long-term complication. SSC. SSP. Subacute sclerosing panencephalitis. Okay, don't mark it as most common. Next, here you can see again eosinophilic inclusion bodies within the cytoplasm. These are called as Cowdrey type A bodies, and Cowdrey type A bodies are known as seen in Cowdrey type A bodies are seen in HSV. Okay, Cowdrey type A bodies are seen in herpes simplex virus. Cowdrey type A bodies are seen in next. A child presents to you with pinkish, pearly, umbilicated papules on the skin. The diagnosis is molluscum contagiosum. Diagnosis is, and molluscum contagiosum is caused by which virus? It is caused by which bodies are seen? Henderson, Peterson body. Henderson. We will discuss जब mat हो जाएगा, we will discuss all the inclusion bodies at one place after that. ठीक है? So please remember, जल्दी से पूछूंगा, जल्दी आंसर करो. Negri bodies in measles में outline inclusion bodies, molluscum contagiosum bodies की बात करें. Molluscum contagiosum, Cowdrey type A bodies, no issues with this. Important. सबसे फेवरेट टॉपिक्स तुम्हारे न्यूरोडिजेनरेटिव डिसीज. Important from exam point of view also. We take it lightly. So here you can see the gross appearance of brain. This is a normal brain, but in this part of the brain there is widening of the sulci and gyri. So this widening of sulci and gyri is due to cerebral atrophy. Widening of sulci and gyri is due to cerebral. What is the diagnosis in this condition? The diagnosis in this condition is a neurodegenerative disease known as Alzheimer's disease. Alzheimer's disease usually occurs in which age group? Elderly, around 60 to 70 years of age group. Alzheimer's usually occurs in which age group? 60 to 70 years of age group. And it leads to what? It is the most common cause for senile or cortical dementia. It is the most common cause for dementia, means memory loss. So the memory loss which occurs with age is called as senile dementia. Okay, and it can be classified if it is cortical or it is subcortical. So cortical dementia, the most common causes. Cortical dementia, most common causes. Senile dementia, most common causes. Usually, if a patient with Down syndrome, okay, develops Alzheimer's disease, there would be a pre-senile dementia. In patient of Down syndrome, there would be a pre-senile. Because in normal individuals, patient will develop Alzheimer's or dementia at 50 to 60 years. But in Down syndrome, the patient will develop Alzheimer's at an early age of 30 to 40 years. Therefore, in Down syndrome, the patient will have pre-senile dementia. No issues with this? Get question answer. Next, if I talk about Alzheimer's disease, definitely most of the cases can be sporadic. Some of the cases are hereditary. What are the gene mutations seen? Anybody? So the gene mutations are presenilin 1 and presenilin 2. The next one is ApoE and the third one is ApoE4. So the gene mutation seen in Alzheimer's first is second is third is gene mutations done. Important. Which is the most important biochemical marker for Alzheimer's disease? It is apolipoprotein E4. Most important marker for Alzheimer's is, most important biochemical marker for Alzheimer's is, apolipoprotein E4. Important. Now, if I take a brain biopsy, which is usually not indicated, if I take a brain biopsy, the most common finding in Alzheimer's would be, these extraneuronal brown colored bodies. These are called as senile neural plaques. So the extraneuronal brown colored bodies are called as senile neural plaques, and they are the most common biopsy finding. So most common biopsy finding in Alzheimer's is, please let me know due to accumulation of which protein these senile neural plaques. एक बंदा को आंसर दे. Sorry. Just क्या है? ठीक है. So senile neural plaques are due to deposition of A beta amyloid. Please remember, senile neural plaques are due to deposition of. Whereas the most characteristic feature they ask you, most characteristic biopsy feature of Alzheimer's, then it is the intranuclear neurofibrillary tangle. So most characteristic is, most specific, most common is neural plaque due to deposition of tangles due to deposition of tau protein. याद रखना, ठीक है. And the inclusion bodies which are again due to deposition of tau protein, these are called as Hirano bodies. Those are called as Hirano bodies. Here for symptoms for Alzheimer's disease you need to remember 4A. Okay, first of all there will be memory loss in the patient. That means there will be amnesia, and memory loss is due to affect damage to which lobe? Anybody? Temporal lobe. It is due to damage to the temporal lobe. Short-term memory loss? Temporal lobe. Which part? याद रखना, memory loss is mainly due to damage to the temporal lobe. Short-term memory के लिए कौन responsible होता है? Hippocampus. Hippocampus is responsible for short-term memory it is. For long-term memory it is neocortex. For long-term memory it is neocortex. ठीक है? So please remember, in Alzheimer's the dementia is usually, or amnesia is due to temporal lobe damage. Apart from that, the second one, there would be parietal lobe damage also. That will cause aphasia in the patient. That can cause apraxia in the patient. Aphasia and aphasia. And last one is anosognosia. That means the patient is unaware of his medical condition. He does not know the severity of his own condition. Okay? So all of these 4 A's are seen in cases of Alzheimer's disease. Okay, so first the patient will forget about the recent memory, and then there will also be loss of remote memory. Important. He will also forget his name, address, and he will keep on wandering here and there. No issues with this? समझ गए? हाँ? A beta amyloid usually होता है. Kidneys में होती है वो usually amyloidosis. Generalized amyloidosis में A beta 2 हो सकता है. ठीक है? तो A beta amyloid होता है. No issues with this? Anybody? Alzheimer's disease. Drug of choice for Alzheimer's. Okay, now, पहले तो cause बता दो. In Alzheimer's, what is the cause? Anybody? Deficiency of which neurotransmitter? Deficiency of, and the most common site is specific बताओ. Nucleus of midnight basalis. Nucleus of. So Alzheimer's is due to deficiency of. Most common site affected is nucleus of. So drug of choice should be a cholinergic drug which will increase acetylcholine. The drug of choice is clonazepam. Drug of choice of Alzheimer's is. The other drugs which can be given would be rivastigmine, memantine, and galantamine. No issues with this. Next, ये हो गया तुम्हारा Alzheimer's. Then next degenerative disorder is when a patient is having a stoop posture, right? An old age patient having stoop posture, shuffling steps would be there. So stoop posture, shuffling steps would be there, right? So this, the patient is having a fascinating gait. The patient is having a fascinating or a Parkinsonian gait is seen in cases of Parkinsonism. So here the diagnosis is Parkinsonism. Okay, Parkinsonism. Important. In Parkinsonism, which type of bodies would be seen in brain biopsy? Lewy body. Okay. Parkinsonism causes cortical dementia or subcortical dementia. Parkinsonism leads to subcortical dementia. So important. Lewy bodies can also be seen in Parkinsonism, even in cases of Lewy body dementia. नाम सही है. Okay. Cortical dementia is seen in cases of. Subcortical dementia is seen in cases of Parkinsonism. Vascular dementia causes. Vascular dementia causes cortical या subcortical? Vascular dementia mainly causes cortical dementia. Vascular dementia mainly causes cortical dementia. Sometimes it can also lead to subcortical dementia, but mainly it is the second most common cause of cortical dementia after Alzheimer's. ठीक है? No issues with this. Parkinsonism, Huntington's chorea, okay, all of these can lead to subcortical dementia. In Parkinsonism, there is deficiency of most common side affected is basal ganglia ka which part? Dopamine is produced by the most common side affected in Parkinsonism is it is due to deficiency of, and here therefore as dopamine is not secreted, so therefore on gross appearance there would be pallor of substantia nigra. Okay, last I'll discuss only symptoms and then I'll give you the break. Symptoms क्या होते हैं? The triad of Parkinsonism. First of all, there would be the most common symptom or earliest symptom would be resting pin rolling tremors. There would be resting. The most common symptom is next, the most characteristic symptom, slowness of movement. There would be slowness of movement is known as lastly there would be stiffness in the muscle, that is rigidity is usually seen. And rigidity, please tell me guys, rigidity in upper limbs it's called as cogwheel. Upper limb rigidity is called as lower limb rigidity is called as apart from this, definitely there would be dementia in the patient. The patient will not write very small, that is called as micrographia is usually seen. Along with that, there would be posturing in the patient. Postural instability would be there. The patient can easily fall down. Okay, so postural instability is also seen, and important, freezing is an important feature. Freezing is also seen in cases of Parkinsonism. Okay, all of these symptoms. I'll give you a break now. Let's meet at 7. Then we will discuss about drugs of Parkinsonism and then neuro further. Okay? 7 बजे तक आ जाओ. ठीक है ना? 7:10. जिनको अगर बोलना है वो 7 बजे बोल रहे हैं. जिनको कुछ नहीं करना वो 7:10 बोल रहे हैं.
ये ना जैसे कि मेटाबॉलिक एसिडोसिस एल्कलोसिस ये मतलब ऊपर नीचे हो जाते हैं सारे प्रॉब्लम. मैं तो एबीसी में बताऊंगा जब बताऊंगा मैं उसके हिसाब से समझना मतलब एबीसी का पता लग जाता है. मेटाबॉलिक एसिडोसिस में तुम्हें इतना ही याद रखना जितना एग्जाम के पॉइंट ऑफ व्यू से आएगा. याद रखना मेटाबॉलिक एसिडोसिस की मैं अगर बात करूं इसका मतलब क्या है? देयर इज एक्सेस ऑफ H+ in the body और H+ कभी अकेला नहीं होता, इसके साथ में पोटेशियम भी राइट होता है. यूजुअली इट इज अ हाइपरकैलेमिक मेटाबॉलिक एसिडोसिस. तो अब इसमें दो टाइप हो सकते हैं, एक तो हाई अनायन गैप मेटाबॉलिक एसिडोसिस और नॉर्मल अनायन गैप मेटाबॉलिक एसिडोसिस. ठीक है, तो हाई अनायन गैप मेटाबॉलिक एसिडोसिस का निमोनिक क्या होता है यूजुअली? व्हाट्स काइट हो गया जैसे कीटो एसिडोसिस. डायबिटिक कीटो एसिडोसिस में क्या होता है यूजुअली इन पेशेंट्स में? ketone body. See, diabetic ketoacidosis usually there would be ketone bodies which is formed, and there is lactic acidosis in the patient, right? Lactic acidosis की वजह से ये metabolic acidosis उनमें develop हो सकता है, right? High anion gap का मतलब क्या होता है? जो सोडियम anion gap निकालते कैसे? सोडियम माइनस पोटेशियम, सोडियम माइनस पोटेशियम क्लोराइड होता है प्लस HCl. SCO2 नेगेटिव आयंस माइनस करते हैं उसमें से. ठीक है, तो ऐसा है सोडियम माइनस क्लोराइड प्लस बाइकार्ब, ये होता है तुम्हारा नॉर्मल अनायन गैप निकालने का. तो इसमें क्या होगा ना, अनायन गैप बढ़ जाएगा. इसका मतलब क्या, ये जो है इसकी लेवल्स बढ़ जाएंगे. पॉजिटिव आयन जो भी होते हैं, सोडियम हो गया, पोटेशियम हो गया, उनकी लेवल्स बढ़ रही है, राइट? H+ आयन की लेवल्स बढ़ रही है. देयरफॉर इट इज कॉल्ड एज हाई अनायन गैप मेटाबॉलिक एसिडोसिस. तो यूजुअली इन सब में यही होगा. कर्ट हो गया पूरा, मतलब यूरेमिया हो गया, डायबिटिक कीटोएसिडोसिस हो गया, इसमें किडनी डैमेज हो रहा है. नींद हर एक कंडीशन में देयर इज मेनली किडनी डैमेज. और किडनी डैमेज जब होगा
तो H plus excretion नहीं हो पाएगा, there will be retention of H plus, retention of potassium, and that will cause metabolic acidosis in the patient. On the other hand, अगर मैं इसकी बात करूँ तो डॉक्टर फ्यूज अगर मैं बात करूंगा, डायरिया हो गया, रीनल ट्यूबुलर एसिडोसिस हो गया, फिस्टुला या यूरेथ्रोसिग्मोइडोसिस, इसमें क्या होगा, डायरिया की एक सिंपल एग्जांपल ले लो, क्या हो रहा है, there is loss of water from the body, loss of water from the body, loss of chlorine, loss of sodium in the body, all of that is lost. So इसकी वजह से क्या हो जाएगा ना, there would be relative increase in the H plus ions or relative increase in the potassium, and that will cause metabolic acidosis in this patient.
वाटर भी लॉस माना जैसे डायरिया में, तो ये H पॉजिटिव कैसे?
H plus वगैरह ये देखो, H plus यूजुअली जाता कब है ना, जब there is kidney damage, ठीक है. H plus मेनली जो reabsorb सिक्रीशन होता रहता है H plus का, ठीक है. तो अगर कोई भी किडनी डैमेज होगा या फिर लॉस हो रहा है, तो अगर सोडियम जा रहा है तो इसका अपोजिट जो ये होता है सिस्टम दैट इज एक्टिवेटेड. अगर सोडियम और वाटर ज्यादा जा रहा है, इसका मतलब वो H plus और K plus को रिटेन करेगा बॉडी. ये बॉडी का नॉर्मल फंडा होता है. अगर तुम इसको दोनों को बाहर भेज रहे हो तो इसका मतलब ये आना ही चाहिए, क्योंकि सेम इंपोर्टर होता है आपका, ठीक है. तो अगर जो सोडियम और बाइकार्बोनेट्स का लॉस करेगा, दैट विल कॉज रिटेंशन ऑफ H plus एंड पोटेशियम आल्सो. सो डायरिया में क्या होता है, इनका लॉस होता है, साइमल्टेनियसली इनका रिटेंशन हो जाता है, दैट कॉजेस मेटाबॉलिक अल्कलॉसिस, ठीक है. तो यूजुअली इतना याद रख लो इंपॉर्टेंट, ये जो निमोनिक्स है वो, इसमें तुम्हें ये नहीं पूछेंगे कि क्या मैकेनिज्म है क्या नहीं, बिकॉज हर एक का मैकेनिज्म अलग होता है. डायबिटिक कीटोएसिडोसिस का अलग है, डायरिया का अलग है. तो इसमें बस इंपॉर्टेंट इतनी ही,
जैसे अपने को ऐसा हो, जैसे कोई रोड ट्रैफिक एक्सीडेंट हुआ तो उसको ना मतलब ऑक्सीजन की कमी है तो उसको रेस्पिरेटरी एसिडोसिस हो जाता है नॉर्मली, तो
ये
साथ में मेटाबॉलिक एल्कलोसिस होगा.
ये कॉम्पेंसेटरी होता है. मैं एबीजी में ढंग से समझा दूंगा. यूजुअली ये फंडा होता है कि जो पीएच होता है नॉर्मली अपना 7.35 टू 7.45 होता है, राइट. अगर पीएच लेस देन 7.35 है, इसका मतलब पेशेंट में क्या है, एसिडोसिस है, राइट. अब इसका तुम कैसे डिटरमाइन करोगे वेदर इट इज रेस्पिरेटरी या इट इज मेटाबॉलिक. अगर PCO2 में कोई दिक्कत है, PCO2 पीएच के फेवर में है, मतलब PCO2 भी एसिडिक है, मतलब PCO2 ज्यादा हो रहा है, देन इट इज रेस्पिरेटरी. या फिर PCO2 नॉर्मल है तो फिर तुम्हें बाइकार्बोनेट्स देखना है, और बाइकार्बोनेट्स अगर कम है, बाइकार्बोनेट्स अल्कलाइन इन नेचर, ये कम हो रहे, दैट मींस एसिडोसिस है अगेन. तो अगर बाइकार्बोनेट्स पीएच के फेवर में जा रहे हैं, देन इट इज मेटाबॉलिक, ठीक है, समझ गए. याद रखना, जो भी पीएच के फेवर में जाएगा उस टाइप का एसिडोसिस होगा. अगर PCO2 फेवर में जाता है, मतलब दोनों एसिडोसिस दिखा रहा है, तो इट इज रेस्पिरेटरी. अगर बाइकार्बोनेट्स फेवर में जा रहा है, दोनों एसिडोसिस दिखा रहा है, तो इट इज मेटाबॉलिक. ये मैं ढंग से समझा दूंगा, एक टेबल बना के दे दूंगा. कंपेंसेटरी यूजुअली उसमें दिक्कत आती है मुझे पता है, बट एटलीस्ट जो मेन है ना, तुम वो याद रखोगे ना. शायद मैंने मेडिसिन में समझाया भी था.
एबीजी तो मतलब आता है, पता लग गया. जैसे सीओपीडी हो गई,
हाँ,
सीओपीडी में क्या
उसमें ये देखो, सीओपीडी में पेशेंट में क्या होता है, सबसे इंपॉर्टेंट बात, उसमें पेशेंट में रेस्पिरेटरी डिस्ट्रेस होता है, डिस्पनिया हो रहा है. मतलब पेशेंट में क्या हो जाएगा, हाइपोवेंटिलेशन हो रहा है, पेशेंट ढंग से वेंटिलेट नहीं कर पा रहा है, राइट. इंपॉर्टेंट बात. तो हाइपोवेंटिलेशन हो रहा है, रेस्पिरेटरी रेट कम है, तो क्या एक्यूमुलेट होता रहेगा बॉडी में, CO2. जब CO2 बढ़ेगा तो ये एसिडिक होता है, therefore the patient will suffer from
respiratory
acidosis, but CO2 की वजह से इसलिए respiratory acidosis, right. So इसीलिए पेशेंट में टाइप 2 रेस्पिरेटरी फेलियर होगा, क्योंकि ऑक्सीजन की लेवल्स कम होगी और CO2 की लेवल बढ़ेगी, ठीक है. दैट इज व्हाट इज टाइप 2 रेस्पिरेटरी फेलियर, ठीक है. तो ये रेस्पिरेटरी एसिडोसिस हो गया. अब इसको काउंटरएक्ट करने के लिए क्या करेगी बॉडी, रेस्पिरेटरी एसिडोसिस है, बॉडी विल ऑलवेज ट्राई टू कम बैक टू नॉर्मल. कैसे भी करके वो नॉर्मल पे आना चाहेगी, तो वो पीएच को न्यूट्रलाइज करना चाहती है. उसका मेन एम होता है, इनकी वैल्यूज कैसी भी हो उसको मैटर नहीं करता बॉडी को मेन तो पीएच को नॉर्मल लाना है बिटवीन 7.35 टू 7.45, ठीक है. यहाँ पीएच कितना है, लेस देन 7.35. तो अब बॉडी को इसको नॉर्मलाइज करना है, तो काउंटरएक्ट करना पड़ेगा. रेस्पिरेटरी एसिडोसिस को क्या करेगी, मेटाबॉलिक अल्कलॉसिस. और वो कैसे करेगी,
बाइकार्बोनेट कम हो जाएंगे, नहीं
बड़े बाइकार्बोनेट्स को, बाइकार्बोनेट्स का रीअब्जॉर्प्शन बढ़ाएगी, ओके. तो यूरिन से बाइकार्बोनेट ज्यादा से ज्यादा खींचेगी बॉडी में. और दूसरा, ऑन द अदर हैंड, इट विल एक्सक्रीट आउट H plus ions. जब H plus ions को बाहर भेजी, अगेन अल्कलॉसिस हो रहा है, ठीक है. तो इस तरीके से वो कंपेंसेट
इसके अंदर मतलब ये SCO3 से 25 होता है, 26
22 टू 26 मिलीग्राम पर लीटर नॉर्मल, ठीक है. 28 तक हम मान लेते, उसके बाद अगर ज्यादा हो रहा हो, इसका मतलब है डेफिनेटली बढ़ा हुआ है, ठीक है. तो अल्कलॉसिस हो रहा है पेशेंट. तो याद रखना, अब ये पार्शियल और टोटल क्या होता है. तो याद रखना, अगर बाइकार्बोनेट्स बढ़ रहा है इसको काउंटरैक्ट करने के लिए, बट स्टिल द पीएच इज लेस देन 7.35, तो ये क्या हो गया, पार्शियल हो गया. मतलब अब तक पूरा कंपेंसेशन हुआ नहीं. बट अगर पीएच इसका 7.4 हो चुका है, नॉर्मल पीएच आ चुका है, मतलब ये कंप्लीट हो गया, ठीक है. तो वो डिपेंड्स ऑन पीएच कि तुम्हारा पार्शियल होगा या कंप्लीट कंपनसेशन होगा। तो इसमें पीएच होगा वो स्टिल वुड बी लेस एंड इसमें पीएच हो जाएगा 9। ठीक, इसकी वैल्यूज मैटर नहीं करेगी, पीएच पे डिपेंड होता है।
सेम फार्मूला उसमें करेगा हाइड।
हाँ, मेटाबॉलिक हो या जैसा भी हो, मतलब वाइस वर्सा इट
ऐसे
रिमेंस।
मतलब जैसे कि मैंने ऐसे रख रखा है कि यदि हाइपोकैलेमिया होगा तो मतलब कि मेटाबॉलिक एसिडोसिस होगा और हाइपरकैलेमिया होगा तो एल्कलोसिस होगा।
मैंने क्या बोला, याद रखना, सोडियम बाइकार्बोनेट और वाटर हमेशा एक साथ जाता है और H+ और पोटेशियम हमेशा एक साथ जाता है। तो अगर तुम हाइपरकैलेमिया बोल रहे हो, हाइपरकैलेमिया मतलब क्या अब्सॉर्ब हो रहा है बॉडी में? पोटेशियम। तो उसके साथ साथ क्या अब्सॉर्ब होना चाहिए? H+। तो अगर हाइपरकैलेमिया बोलोगे तो वो अपने आप एसिडोसिस हो जाएगा। अगर तुम हाइपोकैलेमिया बोलोगे तो इसका लॉस हो रहा है तो H+ का भी लॉस होगा, तो दैट वुड बी आवर लॉस। ठीक है, तो ये याद रखोगे ना, ये दोनों दोस्त है और सोडियम वाटर और बाइकार्बोनेट दोस्त है, तो इजी हो जाएगा।
ये दोनों ऐसे मिक्स हो जाते हैं बार-बार
होता है वो। तो एबीजी जितना प्रैक्टिस कर सकते हो उतना कर लो, इजी है यार। एबीजी इज द मोस्ट इजीएस्ट थिंग मेरे हिसाब से। फार्मा और ये तो सर का है पूरा। हां, फार्मा और ये
इजी है।
एबीजी तो रिवाइज करा है। फार्मा को तो मैंने बताया ना, वो यूजुअली भूल जाते हो तुम बार-बार, तो उसके लिए तुम्हें इंपॉर्टेंट है कि तुम जो इंपॉर्टेंट चीजें जैसे ड्रग ऑफ चॉइस वगैरह ये तुम कहीं चिपका दो और जितनी बार देखते रहोगे दिन में, या कोई बुक है तुम्हारे पास वन लाइनर्स वाली, उसको सुबह शाम देखते रहो, तो फार्मा ऐसे ही याद रहेगा। और जितने क्वेश्चन सॉल्व करोगे फार्मा के उतनी बार याद आएगी फार्मा। लगता है फार्मा भूल गए, ऐसा नहीं है। माइक्रो, फार्मा और एनाटॉमी पढ़ ली है, रिवाइज कर लिए 2 बार, डेफिनेटली आ सकता
सबसे डिफिकल्ट तो एनाटॉमी है।
है। एनाटॉमी का वही चल रहा है। मुझे भी खुद को, मेरे सबसे गंदा सब्जेक्ट ही एनाटॉमी था, बट आई एक्चुअली ओवरकेम इट। मतलब अनिका मैम ने जब पढ़ाया था इट वाज प्रीटी इजी मेरे लिए, तो उसके बाद थोड़ा बहुत तो यार एनाटॉमी का देखेंगे। मैं बस वन लाइनर्स करवाऊंगा, इंपॉर्टेंट चीजें जो आती है एनाटॉमी में वो करनी है और वो बस करके जाएंगे। ये देखो एनाटॉमी में पूछेंगे वो वन लाइनर्स ही, बट बस उनमें इतने कीड़े होते हैं कि वो पहले 3 लाइन का क्वेश्चन बनाएंगे, लास्टली वो वही पूछेंगे कौन सा पार्ट अफेक्टेड है। तो बहुत इजी होता है, बस वही है, वो खेलने की कोशिश कर रहे हैं तुम्हारे साथ।
नहीं अभी एक बार एनाटॉमी घटा रही है आराम से। एनाटॉमी जरूरी है भैया।
एनाटॉमी तो जरूरी है यार
एग्जाम के हिसाब से या बाकी सब
ये देखो, बाकी सब पढ़ने के लिए तो जरूरी है ही, बट ये टाइम अब वो सोचने का नहीं रहा कि एनाटॉमी कितनी जरूरी है नहीं है। एनाटॉमी के क्वेश्चन सॉल्व होने चाहिए, दैट इज योर मेन टारगेट। आए ना आए, हार्ड में जाए, पास हो ना एग्जाम, कोई ये नहीं पूछेगा एनाटॉमी आती है नहीं। बेस्ट है। पीजी की सीट निकालने के बाद कोई नहीं पूछता यार। सर्जरी रेसिडेंट्स है मेरे, उनको एनाटॉमी नहीं पता, उनके लिए तो सबसे जरूरी है। वो अब आके पढ़ रहे हैं फर्स्ट ईयर में जाके, तो ठीक है, नहीं आता सब्जेक्ट सबका होता है, कोई ना कोई वीक पॉइंट होता है, कोई दिक्कत नहीं। उसके पेपर्स बनाओ 2-3 जो इंपॉर्टेंट वन लाइनर से प्रीवियस क्वेश्चन है और रट लो, वो तो बिल्कुल गलत नहीं होना चाहिए ऐसा। और एनाटॉमी और फिजियो ऐसे सब्जेक्ट्स यार बहुत वास्ट है, तो पढ़ाई नहीं जाते इतने वास्ट बट बहुत वास्ट, तो ये कहीं से भी कुछ भी पूछ सकते हैं। अब अगस्त में सी कोई टीचर नहीं पढ़ाता था प्रेप का, मुझे पता नहीं उस टाइम पे, मैंने प्रेप से नहीं किया था, बट लिटरली ये पूछा गया था कि सीक्वेंस क्या होती है यूजुअली इजैकुलेशन में, फिर ये चीजें पूछी जाती है। स्पर्मेटोजेनेसिस की पहले भी पूछ चुके थे, ठीक है, बट इजैकुलेशन की सीक्वेंस कभी पूछी नहीं गई, तो वो भी पूछ लेते हैं लोग। तो यू नेवर नो क्या पूछ सकते हैं।
फिजियोलॉजी में 3 इंपॉर्टेंट, सीएनएस, किडनी और रेस्पिरेटरी,
हाँ,
हार्ट।
ये देखो अब कार्डियो तो इम्पोर्टेंट, कार्डियो तो मेडिसिन, फिजियो का तो हर जगह से इम्पोर्टेंट है। कार्डियो का आधा मेडिसिन कार्डियो से आता है, ये तुम बोल सकते हो, आधा मेडिसिन कार्डियो से आता है लिटरली। अगर कार्डियो छोड़ा है मत छोड़ो, इंपॉर्टेंट टॉपिक्स करो। नहीं समझ में आती कुछ चीजें, मरमर्स हो गए या तुम्हारे हार्ट साउंड्स हो गए, उन पे ज्यादा दिमाग मत खपाओ, उनके होंगे 1 या 2 क्वेश्चन। बाकी कार्डियोमायोपैथी इजी है, पेरिकार्डाइटिस इजी है, एमआई इजी है, वो तो रट लो, वो हो गए ना। और ईसीजी इजी है, इलेक्ट्रोलाइट इजी है उनके ईसीजी, कोई दिक्कत नहीं आएगी।
कार्डियो में तो नहीं है दिक्कत बिल्कुल, कार्डियो सही है।
कार्डियो एंड पल्मो मोस्ट इंपोर्टेंट क्वेश्चन। लास्ट के 3-4 एग्जाम्स में ना ये 2 थे, पहले सब